Good afternoon, everyone. I'm Krista Drobak with Serona Strategies. Thank you so much for joining us today for our fourth vaccine distribution webinar. We record all of these and put them in our website, so you are welcome to come back and watch it later or to send the link to your colleagues. Today, we're going to talk about the role of health plans and employers in the distribution process. I know we've been getting questions, and so we wanted to ask the experts to come and speak with you. First, we're going to have Jeff Wu. He is the acting director of the Center for Consumer Information and Insurance Oversight at CMS, which I know most of you know operates the marketplaces and healthcare.gov. He leads the center's work on policy and regulations for many of the Affordable Care Act's health insurance reforms and the health insurance marketplaces. He is part of the tri-agency team, which includes labor and treasury, and he also serves as the CMS liaison to Operation Warp Speed. We have Amber Rivers joining us. She is going to be available for questions. She is a director in the Employee Security Administration, Employee Benefits Security Administration at DOL. So she is also part of the tri-agency team and will be here to answer questions. Next, we'll have Paul Eiting. He has 15 years of experience in the health insurance world. He's going to be speaking about the role of health plans. He's currently the director of value-based policy at the Blue Cross Blue Shield Association, and he focuses on COVID and the COVID vaccine. So we're lucky to have him. He has served as in the past, a policy director at AHIP, and also worked on Capitol Hill in Speaker Ryan's personal office. And then we have James Gelfand, who is the Senior Vice President of Health Policy at the ERISA Industry Committee, which, as you know, represents many large employers. And so he's going to be speaking to us today from an employer perspective. He has a broad range of experience. He was the Director of Federal Affairs at the March of Dimes. He served at the U.S. Chamber of Commerce, also serving employers, and he worked on Capitol Hill for Senator Olympia Snowe and Senator Tom Coburn, and has covered finance issues and healthcare issues for many years. So we're really pleased to have all three of our speakers today. And so I don't want to waste any time, given how much we have to cover. So I'm going to go ahead and turn it over to Jeff first.
Thanks, Krista. I thought maybe I'd just spend a couple of minutes laying out a sort of a general overview, sort of the vision for how all of this is supposed to work, from distribution to administration to reimbursement, and then I'll talk a little bit about the rules that we have put out and the framework, the reimbursement framework we put out that is intended to cover all parts of the health reimbursement system. And then once everyone, once James and Paul have spoken too, happy to take questions on any or all sort of parts of this. There's many complicated pieces to this strategy. So obviously the national strategy here is to get every person vaccinated, and the way we are doing this is as we distribute the vaccine in phases. And of course, this has been a very big week and a very exciting week for all of that, as the vaccines have been rolling, and over the last 3 or 4 days, they've reached all parts of the country, and folks are getting administered. Folks primarily healthcare workers and folks in nursing homes, both residents and staff. But the intent here is that ultimately, as we get closer to general distribution, the messaging to all Americans is going to be that the vaccine is available. It's very widely available. You can go to any major pharmacy and just stand in line and roll up your sleeve and get a shot. That it's safe and efficacious, and that it's free. And it's free both in the sense that it will be covered by any coverage that you have. Will be covered even if you don't have coverage, and there'll be no cost sharing or balance billing or surprise billing associated with that. And so the intent here is to have that messaging be consistent, have the experience of consumers be very, very simple. I think the last thing we want to do is contribute to any sort of vaccine hesitancy with any kind of financial or administrative complexity or difficulty here. And so the rules and arrangements that we put in place are all intended to back that up. And the role of plans and employers in all of this is to continue to sort of amplify that and support that strategy. So Operation Warp Speed obviously is working with many parts of the private sector to get this to work. Obviously, there's the manufacturers and the distributors and the McKessons of the world, UPS, FedEx, all of those folks are involved in the distribution. There are lots of pharmacy and pharmacy-like partners who are going to be very involved in the distribution, either at providing turnkey solutions to nursing homes or just setting up clinics within their branches so folks can get it when we reach general distribution. And then, of course, we need the payment process to work smoothly. So whether that billing and reimbursement happens through the PBMs or through the medical claims system, and we've also been talking about PBMs and pharmacy software companies, or make sure that all of that happens seamlessly, and then ultimately the insurance companies and the group health plans behind it to make sure that the reimbursement occurs. The reimbursement occurs very smoothly, even with respect to out-of-network administrations, and that the overall communications also is amplified, so that folks are hearing from all corners consistent messaging around safety, efficacy, around the need for everyone to get vaccinated, and the fact that it will be free. And so to do this, the TRI departments, Department of Labor, Department of Treasury, and HHS, CMS in particular, put out a number of rules and set in place a number of arrangements to make sure that the whole reimbursement side of this worked smoothly. We put out interim final rule recently, the most relevant part of which goes to the responsibility of group health plans and insurance companies to reimburse for vaccine administration. Of course, the way Operation Warp Speed works is the government is paying for the vaccine itself and has purchased hundreds of millions of doses and continues to purchase and exercise purchase options within the contracts that the government has signed with all of the leading vaccine manufacturers to make sure that there are hundreds and hundreds of millions of doses available so that the entire population will be able to get vaccinated. But the administration of the vaccine is something that can be charged. And so the way the rules work is that group health plans and insurance companies are required to cover the vaccine at no cost sharing, both in network and out of network. And so this is consistent with our general rules on preventive services, except that for the duration of the public health emergency, this has been the no cost sharing aspect of this has been extended out of network as well. Also, for the duration of the public health emergency, our rules has specified that the importance of making sure that the out of network rate is a reasonable one. And we have pointed to the Medicare rates that we have published as an example of a reimbursement rate that would be reasonable. The Medicare rate ends up being about $45 across 2 different doses if you're talking about a 2-dose vaccine. We have been encouraging state Medicaid departments also to adopt similar levels of reimbursement. In fact, we've been encouraging to adopt exactly the same structure, and many states have said that they are doing that. But many states are also still continuing to work through the precise ways they are carving in and carving out MCOs and the like. So there's still some work to be done on that front. But our rules did provide, so not only on the commercial side, but it did provide specificity as to how payment was going to happen for Medicare. And for Medicare, the way this is working is it's all running through original Medicare. There's a rule within the scope of the Medicare Advantage program such that new benefits that come in mid-year that haven't had an opportunity to be priced, if they are over a certain threshold, and they just get covered and swept in through original Medicare. So all that's being covered through original Medicare. We specified that all Medicaid programs, with the exception of some very narrow single benefit, limited benefit Medicaid programs, are required to cover this as cover the vaccine administration as well. Those limited benefit programs, for example, if you're in a family planning program or something like that, they get picked up along with those without coverage by the Provider Relief Fund, which covers all of the uninsured. And so the Provider Relief Fund can get billed in those circumstances. And so we really have been looking across all of the different parts of the health care reimbursement sector to make sure that there is a common understanding of the billing arrangements and the billing requirements. We've also been taking a very hard look at the logistics of this. So we've been working with PBMs, with medical technology providers, with payers, insurance companies, with the pharmacies, and hospitals and providers, and the pharmacists as well, to make sure that all of this is going to happen smoothly as we get to the more general forms of distribution. We are doing things like sharing lists of providers and the like to make sure that everyone knows how the billing is supposed to work. We're making sure that PBMs are opening up their networks so that wide billing can occur and the like. And as part of this, we have issued a series of toolkits. One aimed towards plans and employers, one aimed towards states, one aimed towards providers, and one for beneficiaries. These toolkits sort of share a lot of the same basic information, but are focused on concerns that would most be relevant to the audience in question. The last thing I think I want to touch on here is that we do think that it is a huge role for both plans and employers is communications around this effort. We as CMS and other parts of federal government will certainly be amplifying the messaging of the CDC on this. The CDC is now starting to provide weekly updates on what is going on with respect to vaccine regulatory matters, the operations of this effort, and the like. And CMS is amplifying that with our beneficiaries, as applicable, and more of the CMS beneficiaries, or folks in Medicare, are going to be coming online in the distribution hierarchy. And we are also sending out that information to issuers and trade associations and the like, in the hopes that you all will also find that useful in your communications with your employees, your communications with your enrollees, so that you can also amplify that messaging. We think that's a big part of it. We have also received questions, and I'm sure we'll talk more about this, about the role of employers as sites of administration, and what the expectations and perhaps rules are around vaccination of employees, and we can get more into that. A bunch of that stuff is a little bit outside CMS's jurisdiction, but general guidance on that is going to which is going to focus around working with the states, because in the end, the way this program is administered is the details are driven down at the state level. The states pull together very detailed plans for distribution of the allotments of the vaccine that they receive. They brief those plans to Operation Warp Speed in quite significant detail as each phase of the distribution occurs. So that's just sort of a couple of minutes spent talking about sort of the big picture. I look forward to Paul and James's comments, and would be very happy, along with my colleague Amber from the Department of Labor, to take questions and discussion on any of these points.
Great, thanks, Jeff. We've already started getting some questions in the chat. So Paul, take it away.
Great. Thank you very much, Krista. I want to say thank you to you and to Sirona for inviting me to this webinar and this series of webinars on the COVID-19 vaccine. As I imagine for many people on the phone, the COVID-19 pandemic and the vaccine particularly have taken over our lives in some regard. I know it got an honorable mention in our Christmas letter this year. So that is just a fact of life here as we dedicate our time and resources to address this pandemic. So to start off, I'd like to talk a little bit about some table setting in terms of what the association has done in terms of thinking about a vaccine. If we go to the next slide, please. Earlier this fall, the association came together to think about what principles we wanted to hold on to as it relates to a future vaccine to treat COVID-19 or to prevent COVID-19 infections. And we started off with a commitment here, a coverage statement that Blue plans will do their part to cover the cost of a vaccine with no cost sharing, as in accordance with federal laws and regulations, and in particular, the IFC4 that Jeff mentioned. And then we went on to talk about some of the principles we hold as it relates to a vaccine. This is an unprecedented effort. We have a vaccine within a year, which is history making in terms of its speed. We wanted to make sure that there is transparency in these efforts to develop and test and ultimately authorize a vaccine. And that transparency is key to building public trust. On the affordability side, we want to make sure that the pricing for a vaccine is affordable and reflects the taxpayer investment once the government is no longer the sole purchaser. Also, given the speed with which the vaccine came to market, we want to make sure that there are post-market surveillance efforts in place to capture any adverse events. And we look to partner as well with the administration on those types of collaborations where we can help identify those adverse events and inform those who are administering the vaccine and patients at large. On the prioritization, we supported a broad and equitable allocation and distribution strategy to address those who are most at risk. We supported the National Academies of Medicine recommendations earlier this year, and we look for states to follow the lead of those recommendations from ACIP as more vaccines are available and as other groups are available for are eligible to receive the vaccine. Along with the prioritization, we want to make sure that we are thoughtful about the prioritization and the access for people who have been disadvantaged and who have been hit hard from this pandemic, people of color, in order to reduce some of the racial and ethnic disparities that exist, not only in vaccines, but in overall healthcare as well. And that includes offering the vaccine at zero cost sharing, and that uninsured are able to get it as well. And then last, there is a need for appropriations for the federal government and for state and local governments to have a coordinated communication and outreach effort to build public trust. There is, as Jeff mentioned, that CMS is looking to the CDC for guidance on messaging. I think the states will be doing the same thing. Blue plans will want to coordinate that messaging as well, and we support a broader concerted effort on that communication and outreach front. Next slide, please. On a more practical level, we've been talking with our Blue Cross Blue Shield companies on some of the operational considerations and how Blue plans can collaborate as a part of the distribution strategy. So one of the things we were happy to see were the CPT codes for the vaccines and administration codes as well, so that plans had those in advance for the first two vaccines, the two front runners, and they were able to incorporate those codes into their systems. And a lot of these considerations are all about removing any kind of barrier to either having a coverage policy in place or having a reimbursement policy in place, so that there are to mitigate any kind of delay in a patient getting a vaccine or a delay in reimbursing for that vaccine. In terms of the claims, we look to see and help plans to identify where they might see the initial claims. Of course, we know the first vaccines are going to healthcare workers and to residents and staff at nursing homes and other long-term facilities. So we help to identify that as well, in addition to when the next groups will be receiving the vaccine. There is also some concern about having the appropriate information and coordinating with non-traditional sites of care. So this includes a state or local public health department that may be administering a vaccine. If they are producing or sending a roster bill to ensure, does that roster bill have the sufficient information to match the patient who received the vaccine to a health plan's member file? And so that member a health plan can identify that member and help to encourage adherence to the second dose therapy. And on the collaboration side, and I'll get into the details on this a little bit later, but the Blue plans are looking to collaborate with their state departments of health and looking to further guidance in terms of communicating appropriate messaging, sites of care to receive the vaccine, who is eligible for the vaccine, since we know that states are going to have some discretion there in addition to the CDC guidelines. And so plans are looking at collaborating and working to collaborate with their states. And then last, the plans are leveraging their relationships with their members, relationships with their providers, with their local community groups on how to communicate all of this information on distribution, on allocation to their members, and making sure the providers that they contract with have the appropriate information too. Next slide, please. On this note, I have a couple of examples from two of our Blue Cross Blue Shield companies. The first one is Capital Blue Cross, which operates in Southeast Pennsylvania, in the Harrisburg area. And this is an example of not the COVID vaccine, but on the childhood immunization crisis that we have in this country. They found a steep drop, 18% of vaccinations for certain pediatric vaccinations, and they raised the alarm on this. They launched an earned media campaign to look at this problem and how to activate their members to make sure that children are receiving their vaccinations. Their CMO spoke on a number of different mediums to get this message out, and they are focusing on education on the pneumococcal vaccine as well. So this is one example of what plans have done this year in response to the COVID-19 pandemic. Next slide, please. The Blue Cross Blue Shield of Alabama plan had a little different approach this year in terms of the flu vaccine. They distributed statewide information to the media about how the flu vaccine is critical this year so that patients who might develop flu will not create a surge in hospital need, and when at the same time the hospitals may have a surge in COVID-19 patients. So they had a concerted effort to reach out via social media. They had earned television as well, and they produced videos on the importance of the flu vaccine. And so this is an example of how a plan executes its relationships with the media and with state and local government, and communicates directly with their members. Next slide, please. So I give these examples because this is the type of communication and outreach that plans do from year to year. Some of this communication is unique to this pandemic, but flu vaccines are a regular part of a company's campaign in the fall. And this is the type of messaging, the type of leveraging of relationships that Blue plans will do as they start to refocus their campaigns as it relates to COVID-19 vaccine. So Blue plans have been developing their vaccine communication strategies. We surveyed plans at the early part of this month, and here's some of the areas where plans are looking to expand their role in the distribution and communication and outreach efforts. And that is, again, working closely with state governments and local Department of Health to make sure that we're coordinating on messaging. There's no need to create unique messaging. We just need to all be on the same page in what we're telling patients and providers who are administering this vaccine. Plans are also discussing mobile vans to reach vulnerable and underserved communities. Plans are encouraging providers to promote vaccines to their patient populations. They're partnering with local universities and urgent care facilities, and offering clinical services to state officials as well. And in some cases, offering physical office space for vaccine administration. So this is just a sample as Blue Cross Blue Shield companies gear up their vaccine outreach and communication strategies, and help to leverage their resources, both financial and leverage their relationships with the provider community and with local and local community groups to get this message out. And with that, I'm going to turn things over to James with Eric to give his presentation.
Thank you, Paul. And let's just roll right into it. I hope you're all familiar with ERIC already. If not, we're a trade association that represents large employers on issues related to employee benefits. So let's talk a little bit about what those large employers are doing, specifically as it relates to vaccine distribution. Going to the next slide, please. So, I think it's worth starting with the fact that not a single one of our large employer member companies has said they plan to try to force their employees to all take the vaccine. And so instead, what they're looking at is how they can be productive partners in encouraging widespread inoculation. They're not sure yet what the rules are going to be surrounding that, because right now there's not a lot of clarity on what the rules are related to any kind of encouragement to achieve good health. And you can thank the EEOC for that, despite great efforts from our friends at the tri-agencies to figure that out. But for instance, will they be able to offer a de minimis reward? Never underestimate what an employee is willing to do in order to obtain a t-shirt. Inducements such as changing the amount that someone might have to pay for their health insurance premiums, right? So you could give someone potentially a discount if they can show that they got their vaccine. What about putting money into a consumer-directed health plan account, such as an HSA or an FSA, as a way of saying, thank you for getting that vaccine? We already do that for people who say that they're exercising or who are managing their diabetes. So does this fit that same model? The exception, of course, is going to be employers that have frontline workers. So I'm thinking about mostly employers that are directly in the healthcare space, but they're kind of a different case, and we'll talk a little bit more about them later. So Ellie, let's go to the next slide, please. Which employees get vaccines first is actually a very controversial issue for employers, because we don't like to treat different employees differently as it concerns our health benefits, right? You want to treat all your employees the same so that they're all getting equal access and equal health benefits, but that doesn't work under the current model for this vaccination regime, because you've got these different tiers, and an example on the screen, right, where healthcare workers come first, and then there's essential workers, which differs by state, and then you've got vulnerable populations, many of whom are on our plans, although we shouldn't know who they are, right? Like, we don't know who works for us that is a diabetic, because we are shielded from that information to protect them from discrimination in healthcare. But this can be incredibly complicated for diversified companies. I was talking to a company the other day that they're an e-commerce company that also owns grocery stores. And the workers at those two different parts of the company are going to be treated differently. And then even at just the grocery store component of that company, they're going to have to treat those employees differently based upon what the local jurisdiction has decided, what the state has decided, who comes first, who comes second, et cetera. So from the perspective of a national employer that is trying to have a consistent plan for their workforce, it's a very difficult time. And there's a lot of wait and see. There's a lot of questions that we're hoping are answered so that we can ensure equity throughout our workforce. So next slide, please. I do want to mention that employers are trying to get directly involved in the distribution chain. The first and foremost is going to be those employers that have pre-existing relationships with on-site healthcare providers, right? So many of the largest employers will have an on-site employee health center, or they used to call it clinic, but they do so much different stuff now. They don't call them clinics anymore. They're health centers. So they're already actually directly plugged in to Operation Warp Speed, and they hope to be on the front lines when we get to those latter stages beyond, just 1A, 1B, 1C. Many other employers, they have direct contracts and agreements with existing health systems where they do a lot of work together, in part because these health systems have a large presence in areas where the employer has a large presence. And so they hope that can later be turned into a relationship that includes helping with vaccination. You know that the two very large U.S. pharmacy chains right now are on the absolute forefront of this, and they are seeing to all of the, for instance, long-term care facilities and nursing homes, et cetera. Well, many of the employers are engaged in relationships with those two chains as well. and maybe looking to leverage that into perhaps some kind of bulk arrangement where we agree that Coca-Cola could send all of their employees to Walgreens or to CVS, right? So that possibility is out there, although we're not there yet because we're a long way from there being enough of those actual vials of vaccine to really be making that plan. Many will be looking for new relationships, and many will be trying to figure out, okay, well, what do we have? What do we have in terms of relationships, in terms of infrastructure, in terms of the ability to push information out to employees and beneficiaries, so that includes their families and sometimes retirees too. So going on to the next slide, please. There are a lot of employers that would love it if their TPAs and carriers and vendors would step up and give some advice. Tell them what are some best practices that they could consider doing. And you should note that a lot of employers still are in a very difficult situation due to COVID. The HR department is short-staffed. They have not been able to backfill positions. They may have even had to lose people. They're still probably working remotely, and they don't have all of this excess capacity to develop a vaccine distribution plan for the hundreds of thousands of people working for this employer. So to the extent that their carrier or TPA may step up and say, hey, we've got something off the shelf that might work for you, or we've designed something specifically that we think you might be interested in, there's a lot of interest. And of course, benchmarking, it shouldn't be a surprise to anybody on the call that employers are always trying to figure out what are our peers doing, what is the competition doing, how can we be seen as being proactive and on the front end of this thing. But there's also some trepidation, what is this going to cost us? Our employees may not very much like us telling them what to do in this area. And by the way, nobody wants to be seen as trying to cut in line, right? And this has actually been very complicated because we know that we need to lead by example, right? So I guess that Vice President Pence is going to be getting a shot soon, and he's going to do it on TV to say, hey, look, this is safe and everybody should do it. But you probably also know that members of Congress are saying, whoa, I don't want to do it, because everyone will say, hey, he pulled strings, he's special, he's getting in front of the line. Well, it's not really any different for CEOs and for HR departments. Now, we do think that probably if we can show, hey, the CEO took the shot, it's probably safe for the line workers to do so too. That might help with take-up, but there's a permissioning involved here, and we need to be sure that there's not going to be backlash. Moving on to the next slide. There are employers who want to directly become distribution centers, not just those with on-site clinics, but those who have space, right? They have the ability to set this stuff up. They're interested in doing it not just for their employees, but also for their beneficiaries writ large, which, as you can imagine, there's all kinds of new things that we need to think about if we're going to be inviting people's families to come to the workplace during a pandemic, and perhaps offering inoculations to people who are not enrolled in our health plan, right? So our seasonal workers, our interns, our part-timers, folks who are not eligible or are not enrolled. But of course, there are many legal problems with that, and we have cautioned our employers, don't accidentally create an ERISA plan that's going to be subject to ACA rules. Don't accidentally create a program that could potentially subject you to new COBRA claims, right? There's all kinds of legal hurdles that we're going to have to figure out the right way to navigate. And of course, if the department so choose, they could create exceptions that would make it a lot easier for us to help to do more broad distribution than just to the people who work for us and are enrolled in our medical surgical plans. But we'll see what future guidance comes out. Moving on to the next slide, please. So just some examples here. I pasted this here just so that you could see that the different states are taking just completely different approaches to defining what is an essential worker and who's going to get what when. And this makes sense because the situation in different states is different, and in certain states there are certain industries that are more important, and perhaps they are on the front lines for the whole country in a certain state, et cetera. So that's great, except if you are a large national employer with employees in 50 different states, or perhaps in every different city, county, and state. That's going to be insanely complicated to comply with. And so, yeah, we appreciate remarks that, you guys should be partnering with the states and partner with your local health departments. But keep in mind for us that that's 50, right? That's 50 different ones plus the territories and DC, right? So it's not actually a very simple thing to do. Even partner with your carriers who are hopefully doing that. Many of our employers work with many different carriers, right? They may offer a large self-insured health plan as well as a fully insured benefit, as well as an HMO for individuals that are on either coast, et cetera. So it's complicated. It's going to take a lot of work, a lot of planning. I guess it's perhaps a good thing we're not going to have access to enough vaccines for another couple months because we're still getting our act together. Going on to the next slide, please. So, you know, we're looking forward to having enough doses that we can get our folks vaccinated. But for the time being, as some of our employers right now are trying to inoculate frontline workers, and I do want to put in a plug that I've heard many folks say that they agree pharmacists should be included in this since they're going to be the ones actually vaccinating our people. So we agree with that. But different states have taken some different approaches to determining who gets what when. Some of them created tiering systems. Some of them created lotteries, right? So like which hospitals we're going to get it first, et cetera. Again, it's a challenge, right? So we could have an employer who has certain workers who are going to be considered frontline and essential in every different state. That still doesn't mean that they're going to have permission to send them to get vaccinated right away. So again, challenges here. We're trying to figure this out. Next slide, please. So, you know, I took some info here from a Gallup poll, and I'll say that as scary as these numbers are, the latest poll I saw was worse than this, okay? The latest poll I saw had the people who saying they were not going to get vaccinated was more than half, okay? But the Gallup poll in November, 60% of people said they'd get the shot, but that number was much, much lower for minorities. Okay, and there's all kinds of reasons why those people are in different cohorts are saying that they don't want to get this shot. I mean, but like it or not, it has been politicized. Okay, there are folks who think that there were politics involved in the development of the vaccine. There are folks who don't trust it, and they're on both sides of the political spectrum. And so one of the things that employers are wondering is there a role that the employer can take in being perhaps a more trusted intermediary, right? There may be many people who, while they might not trust the government and they might not trust the vendors, they do trust the company that they work for. And so perhaps having something coming out and having it be on the employer's letterhead with the employer's logo, that might be what it takes to get some people to say, you know what, okay, I'm going to do it. I'm going to get the shots. So we're cognizant of that challenge, and we're wondering if perhaps employers can help to bridge that gap. That right now, I think there's a lot of trepidation about what is it going to mean when we're trying to vaccinate the country if half of the people in the country aren't even willing to get the vaccination. So going on to the next slide, you know, in conclusion, we feel that the private sector played a critical role in developing the vaccine. We're super proud of Pfizer and Moderna and AstraZeneca and those other companies that helped to get us to where we are today. But now it's time to take the next step, and employers want to be a part of that. And so, you know, CVS and Walgreens are leading the way, and you know, hats off to them. But what could a GM do? What could a company do that has a clinic, that has space, that has a large concentration of workers? We want to do that. And while previously we might have been a little bit hesitant, the departments, including DOL, have taken some incredibly important steps to ensure that we can safely do that. And so I did want to point out, Jeff already talked about it, but the recent rule that came out and said that out-of-network providers cannot charge ridiculous prices for the administration of the vaccine, that is so important. I cannot stress how important it is because we are still struggling with the mandate to cover COVID testing. Because most providers and most hospital systems are honest and fair, but I still do see coming across my desk every day the example of an individual who went to an out-of-network provider to get a COVID test, and that $25 test, not only do they charge $500 for the test, but they also charge $2,000 for the privilege of walking into the office because the provider and his office had been purchased by a hospital system. And if that was going to happen with the vaccines, it would have been an absolute disaster. So hats off to DOL and CMS for making it so that we don't ever have to worry about that happening with the vaccinations. And we're cognizant that everybody wants to return to their normal lives. I mean, so do we. We'd like to reopen. We'd like to get back to making stuff and selling it. But we've got to get the world vaccinated so that people are comfortable not just coming to work to make the stuff, but coming to the shop to buy it. And so we've got to have a nationwide plan to make that happen. If there's anything that we can do that shows that we're a part of the solution, but not that we're, self-interested and just trying to get our own business off the ground, that's something that I think all of the employers are very, very interested in. And with that, I'll hand it back to Krista to moderate the Q&A.
Thank you very much, James. Thanks to all three of you. The first question is really for Jeff. I think I'm putting in the chat a New York Times article that appeared talking about surprise billing. It was in this morning's New York Times. Are there circumstances under which providers could pass along some costs to patients?
So the answer to that is no. Every provider that receives, so I'll say there's a fraud piece of this that we can talk about in a second. But in terms of legitimate charges, the answer to that is no. Every provider that receives shipment of the vaccine for distribution signs an agreement with Operation Warp Speed. That agreement prohibits the provider from charging any consumer anything. They can't charge copay, co-insurance, they can't balance bill them, they can't surprise bill them. That consumer receives the vaccine free of charge. The provider cannot must vaccinate every person that comes to them, regardless of coverage status, regardless of whether they have this plan or that plan or no plan at all. To the extent that the consumer is uninsured, they can build a provider relief fund. That fund stands ready to pay for the administration costs. The one asterisk I wanted to sort of add there is we are aware that certainly that there's a potential for fraud, for fake clinics to stand up and claim that they're administering something, or folks to sort of call people on the phone and say, hey, pay $100 to reserve your spot in the distribution chain, right now, sort of thing. And certainly CMS is aware and is working hard to address those kinds of potential situations. But the way the rules work with respect to providers who are receiving shipments of this vaccine, of any of these vaccines going forward, they cannot charge any consumer anything.
Thanks. Paul, is there a solid requirement that insurance companies provide an administration fee to providers? We have heard that there's some variation in the way that insurers are approaching payment, and I wasn't sure if that variation was just different negotiations around how much they're going to pay, or if the variation is whether they're going to pay or not.
Thanks for the question, Krista. I think their plans are probably thinking about this two ways. One is negotiating those administration rate fees with their in-network providers. And so this is something they do for all new services. And something I'll note that if you choose to go see an in-network provider for any service, there are often or most regularly those balanced billing protections in those contracts. So that's kind of built into the health plan provider networks that we all know and love. On the other side of the table is the issue of out-network providers. And we completely understand the tri-agency's decision to require coverage for out-of-network providers who are administering this vaccine. This is a pandemic. We can't control who might get this vaccine, if its provider happens to be in a network or not. And so we want to make sure that Blue Cross Blue Shield members are receiving access wherever they can get it as appropriate. And I think it's just as appropriate for CMS and the other agencies to dictate that there must be a reasonable rate paid for these out-of-network providers to make sure that they're getting paid for those services, and listing out the Medicare rates as one example of a reasonable rate.
Okay. James, I think this is most appropriate for you, is that individual employees will want to figure out how they can get vaccinated, and a lot of it will be up to them, I guess, to go to their state websites. And you have many multi-state members who operate in many states. Are any employers thinking about aggregating the information from state websites on what who's in the priority group and who's eligible and all that kind of information into some sort of an internal employee communications search function?
I think every employer is looking into the possibility of being able to provide that information for employees. It'd be great if somebody would do the work for us and just hand it to us so that we could know, based on what state you're in and what your responsibilities are. Here's your rank and when you should do it. But if nobody else does, then each employer on their own will try to figure out how that works, because the employees are looking for information. Remember, many of them want to get the vaccine. They don't want to show up and be told, oh, you're not eligible right now, but thank you for standing. I guess you have to set up an appointment first. But there's still possibilities of accidentally going when you're not supposed to go, or et cetera. So I guess it's a long way of saying we hope that it ends up being aggregated on the federal level, so that perhaps a website that the federal government puts together pulls that data and helps us to use it to extrapolate to our employees where they fit into the scheme of this.
Okay. Jeff, is the Operation Warp Speed considering the helping citizens locate and schedule appointments and figure out if they're in the priority group? Is that fully a function of the state?
So there's a bunch of that certainly is a function of the state, as James has pointed out, all of which is true. The CDC has a website up that is it's called Vaccine Finder. It is not loaded for the COVID vaccine just yet because it is not available for general distribution. But as we hit that phase, Vaccine Finder will be updated, so any person can go to the website and see a map of all of the places close to them or wherever that are distributing the vaccine. So that will help folks know where to go to get it. That doesn't sort of fully answer the question. Your question also went to sort of tiering and all of those sorts of things, and that part of this of this operation does lie with the states. Like I said, the state, the CDC will set sort of the broad overall guidelines. The states then implement and interpret. They do bring their plans back to Operation Warp Speed so that they, and brief them so they're sort of broadly consistent. But I do think the Operation Warp Speed structure very much recognizes the role of states in implementing this complex arrangement.
Okay. There's a question about the requirements that grandfathered plans cover the administrative fee, and if there are requirements, what guidance can they refer to? Yeah,
so grandfathered plans, not every kind of commercial plan is, and so I'll make this larger than grandfathered plans. So there are short-term plans out there, there are indemnity plans, there are all kinds of other forms of commercial coverage that aren't swept in by the regulations. Again, those folks who have that kind of coverage, it's all going to be transparent to them. I mean, they're going to walk into a CVS or a Walgreens or wherever, and that provider is going to be under an obligation to provide the vaccine regardless of coverage, no cost sharing, no charge, anything. So from a consumer perspective, they're just rolling up their sleeves, they're getting the vaccine, and they're walking out, with a card for when to come back. On the back end, like I said, for folks who are uninsured, the provider relief fund will be available. For folks who don't have, let's call it sort of full coverage or sort of underinsured, perhaps in these sorts of plan categories, we're working hard right now with the provider relief fund to make that compensation available as well. But regardless of how we settle that, the arrangement with the provider is such that to the consumer, none of this matters. It's all available and free to them.
What conversations are the three panelists having with the Biden transition team? Are you all already talking with how this is going to work as we transition to the next administration? Paul, why don't we start with you, and then James, and then Jeff?
Oh, thanks, Krista. That's a good question. We are engaging with the Biden transition team, and I can't say. I saw the question in the chat. I can't say how they're going to stay the course or alter course once they come into office, but we are sharing some of the same concerns that we've shared with this administration and with the Hill. The long-term affordability of a vaccine is a key issue for Blue Cross Blue Shield companies, and knowing when Blue Cross companies will be on the hook for that cost. We're eager to have more appropriations for that communication and outreach effort that I mentioned earlier, to make sure that there is sufficient funding for CDC in the states for this distribution. We know the CDC has requested funding for those distribution efforts. It seems like the distribution has gone forward pretty flawlessly so far, but we want to make sure that the resources are there so that continued success, that success is continued. So yeah, we're having those conversations on this topic and other issues related to the pandemic, and we look forward to continuing to talking with them until they're in office.
Yeah, the employer groups talked to the Biden team about this a day or two ago, and I think that they felt that they wanted to build upon the progress that had already been made by the agencies. They asked us what they could do to be helpful, and I think the things that were in the slideshow are the things that we told them, right? The lack of having a consistent national scheme is going to be tough for certain employers that are national. We're extremely thankful for the IFR, and so we want them to please keep it in place, and if they can, use it as a model for how to address testing. And we're also looking to continue to grow the partnership between the federal government and the private sector as we get into a broader distribution phase to more people, where we could potentially serve as like a physical catalyst to getting people inoculated.
And I don't have a ton to add here. We've certainly been in conversations with the transition team, or at least the agency review team that's specific to CMS on a very broad range of topics. Certainly, all COVID and Operation Warp Speed topics have been very much at the forefront of those discussions. So a lot of discussions and briefing has occurred. I know that they have also had direct briefings and discussions with Operation Warp Speed directly. I don't know that I have any information to share as to any sorts of changes. My general sense, I will say that is that I do think they very much want to build upon what's there, and I think they all of those folks similarly place this as a very, very high priority, sort of the smooth execution of broad vaccination.
So this next question is sort of a two-part question. The first part is for Jeff on whether there's a consideration by Operation Warp Speed to freeze any of the prices related to the supplies that are necessary for vaccine administration. There's one case in the chat of gloves that have increased fourfold over the past month. And the second part of that question then is for Paul. How do health plans account for, I guess for lack of a better word, price gouging around the vaccine? So for a provider that wants to administer it, they've got a set price that they've negotiated, which may be, around or a little higher than a flu shot, but you don't have a run on gloves and syringes with a flu shot. And so there could end up being more expensive to administer the vaccine. And does the reimbursement take that into account? So Jeff, first on the Operation Warp Speed.
Yeah, sure. So on the Operation Warp Speed side, I'm not aware of sort of imminent discussions of this sort of thing, though I will say that these sorts of supplies are monitored very carefully by Operation Warp Speed and folks associated with it. As part of, I do remember in the early months of COVID, working with FEMA, and FEMA was tracking all of these sorts of supply shortages and the like. very, very closely and trying to step in when they could to try to alleviate, though there just, there were shortages, certainly, as we all remember. So I do think that this is sort of on the radar. I do think they have operations in place to sort of watch this. I do think that a lot of, especially sort of these early phases of distribution, comes with not only just the vaccine itself, but a lot of supply of parts and PPE and the like. Though I'm not sure that will happen sort of throughout the full distribution of the vaccine. So I do think it's something to watch. I do think folks are aware and watching all of these aspects of it very carefully. And there are mechanisms in place that have been were used earlier in this crisis to some effect as well.
And I'll add that a couple points. On price gouging in general, that's a concern we've had and expressed, from the early days of the pandemic. And as James alluded to, we've seen this firsthand with the exorbitant prices of some of the testings that we've seen from some providers and labs. And I see that less of an issue on the vaccine side, given the protections in the IFC4 that Jeff mentioned and the protections in the contracts that providers sign in order to administer the vaccine. And then specifically to the price gouging around materials or the cost of administering the vaccine. I know Jeff can speak to this more specifically, but the CDC is sending out supply kits to the providers who have these contracts, which will have the equipment necessary to administer it and to provide a card to the patient to know when they come back. So I think some of the cost of that will be covered by the materials that the CDC will send. I know that each Blue Cross Blue Shield company, each insurer is going to make their own reimbursement decision here in terms of, do they have an administration rate that's similar to the flu? Do they add a little bit more to consider that there are some PPE expenses that need to be covered here? So I think that's definitely consideration as plans are considering how they negotiate these rates with their providers.
Great. James, you mentioned that there's that there might be a anti-price gouging bill in the omnibus, in the text. Do you want to elaborate on that? What's the mechanism by which they could, what's the authority to stop price gouging?
I mean, it would be creating a new federal authority to do so that doesn't necessarily exist today, at least not in the form that they imagined it. And they were looking at broad-based approach to many different things, so not just PPE, but also testing, et cetera. I don't know, though. I don't want to overpromise here, because that was a provision that appeared in the House HEROES Act. But the legislation that they're supposedly have agreed to in the last waning hours of last night, there's no guarantee that it includes so-called extraneous provisions outside of large funding injections into various programs. So we're all kind of waiting to see what if anything is included, and if so, what does it look like, and what will be the operational effect that it will have as we go out there purchasing many different aspects of healthcare related to it.
Great. There was a question in the chat about whether a PPE fee can be charged to patients related to the COVID vaccine. I guess that's happening on testing. Jeff, we only have 30 seconds left. Is the answer yes or no?
The answer is no. There's no charge to the consumer for anything.
Okay.
So, the testing situation is quite different and unfortunate because of statutory language that was passed that relate to testing.
Okay, great. Thank you, Paul, James, and Jeff, and thanks, Amber, too. Really appreciate all the information, and we'll send out the recording in case others who want to listen to it, but this has been really helpful. Thanks again.
Thanks. Thank you. Take care, all.